What's up, guys? Welcome to Airway's EMT Education. I'm Robert Roy. I'm the owner of the company, and we are going to be going over some of the stuff that's inside of an ambulance, particularly the equipment that you're going to use when you're in the field. Some of the stuff that you see here is going to be things that, yes, we had them on the ambulance, but you're actually going to be carrying them in your bag. So you're going to be learning about these in various chapters throughout your training, and everything is designed that we're going over today to maintain your three, or at least two of the three, life-saving interventions that you would be able to do for somebody that may otherwise not be able to survive on their own. If you think about it, you have to have, as we learned in our primary assessment, your airway, your breathing, and your circulation, right? So me sitting up talking to you, I have all three of those. I've got an airway. I'm able to move air in and out. I am able to breathe. I'm getting oxygen into my blood supply to my cells, and the carbon dioxide is coming out. And then we also have the circulation aspect where the blood stays inside of my vessels and goes around and around. If anything in there gets messed up, particularly to a bad extent, I'm not going to survive, and neither would anybody else. So we have tools to help with that, and depending on what you see on your scene, you may or may not have to use some of these. So the things that we're going to go over today are we're going to start off with our airway adjuncts. There's a few that you get to use as EMTs. There's a couple that are advanced beyond that you'll learn if you go on to our higher levels, but they won't be in this video. Then we're going to talk about breathing and how we maintain a patient's ability to breathe, particularly oxygen is what we want them to have, a certain amount of it. And then we will do the circulation stuff in a later video because it really doesn't fit what this video is going to go into. So to start off, let's talk about airway. Anytime that you have a patient that has a pulse and is up, whether they're up talking to you or not, it really doesn't matter. If they're unconscious but they still have a pulse, you're going to do it in this order. If they are alert and have a pulse, you're going to do it in this order. But for airway, we have a couple of items. We have an oropharyngeal airway, or we call it an OPA for short. We have a nasopharyngeal airway, or NPA for short. You'll hear people in the field, your instructors may call them OPAs and NPAs. All of that is just, they're referring to these two things. So we're going to start with these. The OPA, oropharyngeal airway, is named because of where it goes. Same with the NPA. So if I'm trying to create an airway in somebody, let's say that they're unconscious, and you can hear snoring respirations. If you think about your studies, what snoring means is that the tongue is getting stuck, kind of flapping in the airway. So it's not snoring like you're asleep where your nose is causing it. This is where you've lost muscle tone, you're unconscious, you've lost the ability to maintain your tongue in its normal position. And now whenever you go to take a breath, your tongue is flapping and it's creating a snoring sound. So anytime you hear the term snoring, or in the field if you see snoring, these are going to be the devices that you use. So the OPA, being oral, means it goes through the mouth. This is a great tool. It's quick. It does a very good job of keeping the tongue off the back of the throat. There are some problems with it though, right? So indications would be that your patient is snoring and does not have a gag reflex. So if you think about it, if I'm going to stick this down my throat, if I have a gag reflex, if I'm any sort of conscious at all, my reflexes are going to be intact, and I'm going to start to vomit, which is going to cause a whole other slew of issues. So you want your patient to be completely unconscious when you use this. You're going to measure it off. They do come in different sizes. Some of these that you see in the field are going to be kind of color coded. You'll get used to the different colors, but don't take that for granted. Still actually size this up so that you use the right size, because if you get one that's too big or too small, it either A, won't do anything, or B, is going to cause more problems as well. So the way that this is measured, I always say bone to bone when I'm teaching. So your teeth are bones, and then you have your jawbone here. What I do is you take it, you line it up with the patient's side of their face, and the front should be flush against the teeth. The back side should be up against the corner of the jaw where it kind of curves up toward the ear. As long as you're touching it and you're not too big or too small, that's going to be the good size. It is a bit of a rough estimate, so if you get one it's pretty close, all right, remember, time's typically not on your side, so if it looks right, cool, that's what you want to use. To put this in, you're going to turn it upside down, and you're going to take this and bring it across the roof of the patient's mouth. Once you get to the back, rotate it into place. This should fit over the tongue, so my tongue's going to be where my knuckles are. This will be at the front of the teeth, and then depending on the design, whatever manufacturer made the ones that you deal with, they may be a tube like this, or it may look kind of like an I-beam where it's a flat piece that goes that way and it's got two, a top and a bottom running perpendicular to it. Either way though, what happens is that this thing hooks around the top of the tongue and holds it in place, and air can move around it. We're going to talk more about the design of this and why this is important when we get to things like the suction, because you may have to do that as well. Let's say that my patient has a gag reflex though. All right, so they are somewhat unconscious, right? We have those 4 levels. You have your alert, which is what we all are right now until I put you to sleep. We have verbal, which means that your patient's starting to kind of nod off, but you shout at them and they're, huh, what? They hear you, they respond. Even if it's a groan, if it's a if that's all you get, that still counts. If that doesn't do anything, and we do the painful stimulus where we sternum rub somebody, if it's an infant, you can flick the foot, things of that nature. And they respond either by pulling away from you, grunting, closing in, some kind of response, that counts as well. If your patient's anywhere in that range, they're probably going to gag on this. And then now you can't use it. If you try to use it and they gag, you're going to have to suction the airway, and as long as this is in place, they're going to continue to gag. So we don't want to keep this there. If that happens, you just remove it, and then we're going to move on to this. Again, if they're already, like I said, they're in that in-between stage where they're not alert, but they're not completely unconscious either, you can actually forego this because you can assume that they're going to gag on it and switch to your NPA. The way that the NPA works is it goes through one nostril. So the way that we use these, again, just like the OPA, we have to measure. But unlike the OPA where we're going bone to bone, I want you to think about these from cartilage to cartilage. So because you're entering at the nose, we know that the tip of this, the flange is what they call it, is going to be flush up against the nose. The other tip of this is going to go to the earlobe. All right, so unlike the OPA where it's bone to bone and it's a shorter length, the NPA has to go further, so it needs to be longer. You're going to go from the nose to the ear. So you put this in place. Notice that mine is significantly short. That's all right because I'm just demonstrating this. But if I were a real patient and I had this to my size, I would have to grab a bigger one. You can lube these up. If you do use lube, this is very important, possibly in a test, but definitely know this when you go to the field. Do not use oil-based lubricants. So if you've got Vaseline, for example, don't use that with this. Oil and oxygen don't play well together. We don't want to cause a fire hazard or a combustible hazard on our patient's face. Use a water-based lube. They typically come with this, so if you're opening this out of a pack, you should have a little thing of lube that's in there with it. If you don't, check with your bag, look around in your truck, you probably have something, and if all else fails, you can either use, I know this is gross, you can either use blood or saliva. So you can open your patient's mouth if it's not, bone dry, stick it in just to wet it. Now it's lubed up and it will be able to fit into the nose easier. When you actually go to insert it, we have the beveled edge. So the bevel is going to point toward the septum. So as I've got it right now, an easier way of looking at it is the tip itself goes to the outside of the nose. So if I'm going to come in on this side, then I want the tip to face this direction. If I'm going to come in on this side, I want to flip it so that the tip is on the outside, but the beveled end goes toward the septum. Remember that because that may be how it's described in a test, or if anybody's asking you questions about it, bevel toward the septum. You'll go in, and then once you meet resistance, a little bit of resistance, you're going to start to twist, and it will continue to push into place. There is a contraindication for this, but it's not a direct one. So if you have a patient that's got, let's say they were in a bad accident and they broke their face, we have what's called Lefort fractures. You'll learn about that when you get to trauma. If they've got a really bad facial fracture and you try to push this in, if you're not careful, you could push into the brain cavity, and then now we have bigger problems. So if you go to insert this and you meet resistance and it feels like you're hitting a wall rather than just a tighter space, back up a little bit try again. If you feel like you're hitting a wall again, then just don't use this. All right. There may be times you have a patient where neither of these work. Unfortunately, this is the limits of the EMR and the well, actually this is above the EMR, the EMT toolkit, depending on where you are. We will go over things like the King Airway and the iGel and some other things that stay above the cords. They're called supraglottic airways, but that will be at a later date. These are your typical go-tos right out the gate. If you can't use them, you may have to hurry up and get additional help on the scene, be it a paramedic or an advanced EMT, any other provider in the field that may have an expanded toolkit beyond your own. All right, another airway device, and we're going to talk about this one twice actually, because it's both an airway and a breathing device. This is called the bag valve mask, and I know that I don't have the mask on here, but it's going to look just like a pocket mask that we're going to go over in a second. It just connects on. You would make the seal and then breathe. So it's called a bag valve mask, or BVM, because we have the bag, which is this football shaped portion here, the valve, which is this red flap. You can kind of see it a little bit right there, and then the mask, which is missing, but we'll explain that when we start talking about the pocket mask. So this is both an airway and a breathing device. We're going to talk about it as an airway device first. If you think about it from your studies, you're taught that all of your airway adjuncts have to be above the cords. Everything BLS, or basic life support, that an EMT can do stays above the cords. Only a paramedic can actually use an ET tube with a laryngoscope where they hook the patient's face, put the tube past the cords, inflate the cuff, that kind of thing. That's the best airway that's out there, but only a paramedic can do it. This is an exception to the rule. As an airway device, this doesn't, yes, we're not going into the body with anything plastic, right? All of this stays outside the body. However, this is designed to open the airway all the way at the bottom of the lungs. If you think about your anatomy, you have your upper airway, your lower airway, and then when you get down to your lungs, you have your alveoli, which is where the gas exchange happens. So if we're dealing with patients that have congestive heart failure or near drowning incidents, anything of that sort, we can use this to clear some of that fluid out of their lungs. That way they're able to breathe. So if that's the case, you would just make your seal, and when you breathe in, you're creating pressure. As long as you're creating more pressure in the lungs than what's outside the lungs, it'll push that fluid back out. So that is an airway fix. If you're going through your assessment, and you, depending on your patient that you present in front of you, and you're thinking about all the interventions you have to do for whatever your scenario is, you may use this at A and B, A or B. It just depends on what you're using it for. All right, same thing. So if I'm going through my primary assessment and I get to A, which is airway, if I have to use these, that's where I'm going to do it. Same thing with this. If I have to clear out fluid from the lungs, I'm going to use this to clear out the lungs. However, this is also kind of a murder weapon if we're not careful. So we want to make sure that we use this properly and that we know the dangers of using it. We're really bad in the fire service, particularly, about throwing this to the new guy and being like, here, bagging is easy. You do this while I'm dealing with everything else that has to go on with the patient. There is a big issue, though, that we don't really think about. For one, your lung capacity, the average adult lung capacity is about 500 cc's, so a half of a liter. This bag right here, if I were to squeeze the whole thing, I'm pushing in almost a liter and a half. 3 times the amount of air that needs to go into a patient's lungs. The lungs are only going to hold so much. Anything else that I push through for an adult is going to go into the stomach. And we don't breathe through our stomach, right? So any air that goes into the stomach is just going to stay there. And then the next time I give a breath, the same thing happens. 500 mLs or cc's goes into the lungs. The remainder goes into the stomach. And I breathe again, and eventually the stomach is going to get full. If you think about your anatomy again, your stomach actually hangs out below your diaphragm. Your diaphragm separates your abdominal cavity from your thoracic cavity, which is where your heart and your lungs are. So the more we inflate the stomach, the more the diaphragm is not able to really push down, and your patient's unable to take a good breath. So it's going to get to a point where you try to give a breath, you can't do it because your patient that now looks like they're 9 months pregnant with this bloating in their stomach just doesn't have the real estate to move their diaphragm to allow their lungs to expand. So this could actually kill your patient if we're not careful. There's a couple of things that we can do. to make this better. One, we can lessen the capacity of this balloon, right? So these usually come collapsed. Instead of popping the whole thing open and then squeezing the whole bag, leave this side in. Now, when I squeeze, I'm catching the inside of this. It's reminding me not to squeeze this whole bag. Secondly, I can use a pediatric bag. They do come in different sizes. We have the adult, which is this one, which is really built more for an NFL linebacker than an adult. And we also have a pediatric and an infant. Your pediatric ones are right about 500 cc's, which is what we would want for an adult. They also have a safety mechanism that allows extra pressure to kind of pop off and blow out of here. So instead of being shoved into the stomach, it will just release out of the BVM, and then we don't have that problem, at least not for a while. But the important thing is that if you're using this, and you can remember this in any other trainings that you've ever taken that talk about this, when we breathe for our patient, we're only looking for chest rise. So even if I don't collapse this or use a pediatric bag, I may only squeeze this much. I don't know if you can see that. So maybe a third of the bag gets squeezed, and I'm going to see chest rise from my patient. That lets me know that I've given enough of a breath. It's not about squeezing this whole bag. We will very rarely ever squeeze this whole bag, at least not by, by what we need to do. If you show up on a scene and you see another provider or maybe somebody in training, because remember, not everybody's an EMT, not everybody's an advanced or a paramedic. Some people are EMRs. Some people may, depending on the fire department, for example, some people may not have medical training beyond CPR. And then when the emergency hits, tunnel vision kicks in. Like I said, we hand this to our new people because it's easy, and they are cranking down. They're both hands or using their leg or anything like that. If you see it, stop it, because once we overinflate the stomach, only a paramedic can deflate it. We don't want to get them there. All right. The other thing about the airway, we've talked about what happens if I hear snoring, right? Snoring means the tongue, so I'm going to be using these. We've talked about what we're going to deal with if we have fluid in the lungs themselves. We've talked about the BVM. So near drowning victims, congestive heart failure, which you're going to learn about when you get to that chapter. What if somebody has fluid in the mouth, right? So it could be blood, it could be loose teeth, it could be anything in the mouth that kind of occludes the airway. Maybe they were a diabetic and they were trying to drink some juice, but they went unconscious before they could, so they've got the juice in their mouth. This fixes the tongue only, which fixes snoring. It doesn't do anything for that kind of fluid. This only fixes fluid that's already down at the base of the lungs. It really doesn't, it'll just make it worse up here. So what we have here, and there are different models that are out there, depending on if you work in an ambulance or a fire department, things of that nature, you're going to have what we call a suction. And that may be a handheld suction, it may be a portable suction that's mounted on the wall that you can take with you. If you're in an ambulance or in a hospital setting, we have them mounted on the wall. So the way this works is we'll turn on the suction. So we're going to turn on the suction. Make sure that it's connected. You should have a line running from the wall, which is where the suction connects, up to the top of the collection chamber. As you can see, this one's not completely set up. There's going to be another connection here that runs a tube to where you're actually going to suction from your patient. As you're suctioning, it'll pull through, collect into this tube, and then you just kind of take this with you to the hospital if you're going to be transport, hand it to the ambulance if they're going to be doing it, or if you're already in the hospital, just leave it on the wall. The important thing here, as you can see, the gradients, the important thing is that we want to know how much fluid we've been suctioning out of somebody. That's the only reason you really keep this. Other than that, you can look inside of it and see what you're dealing with. Am I suctioning blood? Am I suctioning orange juice? Am I suctioning baby formula or broken teeth? Things that may be traumatic in nature are going to be in here as well. When we suction, there's a couple of things that I want you to remember. One, if anybody asks you how long you suction for, in the real world, we're going to suction until the patient's airway is clear. However, there is a time limit that's attached to it, particularly for school. They want you to know about this. It's no more than 15 seconds. And the reason being is that the longer you are spending time suctioning, the less breathing in oxygen, which is what we're going to talk about next. When you suction, we're going to suction from the inside out. So if I have a patient that's laying on his back right here, and his head is on the stretcher and he's looking up at me, I'm going to take the tube that doesn't exist. We're going to imagine that I've got it, and there's a tip on it called a yanker. It's a hard straw that you stick in the mouth, kind of like with the dentist. If you've ever been to the dentist and they're suctioning the spit out of your mouth, it's the same thing. It's just a little bit bigger. There's a hole on it that you'll put your finger on. As long as your finger's not on it, air is coming in through that hole up by your hand and not at the tip. So you can put that into their mouth and nothing happens. When you put your finger on that hole up by where you're holding it, now you've closed it off. So suctioning is going to come from the tip, which is in their mouth. And you'll suction, making circular motions on your way back out. So don't suction your way in, suction your way back out. If you suction on your way in, you're probably going to catch the tongue, you're going to catch different things, and then it's going to close off, and it's like having a vacuum cleaner getting stuck to things. It's a lot harder to do. So put it in the mouth without creating the suction. That way you're not sticking to everything. Create your suction, and then work your way back out. It goes much faster, it's much better at getting all the fluid out of the airway, and then you actually can start to breathe through your patient. Once we have fixed A, we can move on to B. B stands for breathing. So when we talk about breathing, we're not talking about necessarily getting the air in and out, right? That is the airway. We want to make sure that the route's there. For breathing, we want to make sure that what they're breathing is adequate. Normal O2 is 21% in the air around us. So if nothing else, if I were going to bag a patient with just this and nothing was connected to it, they're still getting room air. They're getting 21% oxygen, which as I'm sitting here and you're sitting there, hopefully I haven't put you to sleep yet, you realize that that's all the oxygen we need. Anything beyond that is a benefit, but as long as you're getting at least that, we're good. So the only time this would really be a bad thing is if you're still in an oxygen deficient atmosphere. In other words, maybe it's carbon monoxide poison or a structure fire for the firefighters in the room. If you're still in the smoky environment, whatever's around you, that's what you're putting into your patient when you bag with this. So if you have to, try not to overthink it, get your patient to a clean environment. All right, so what I want to start with is going to be oxygen itself. Now, this is an O2 tank. A couple of things to note. A lot of them are different up here. Depends on the company that you get your O2 from. Some of them require you to assemble it yourself. Some of them come pre-assembled like this, and the designs can be radically different, but they all do the same thing. So I'm going to show you where everything is on here. Every O2 cylinder is going to have the same thing. It just may not look exactly like this. So the first thing is the color. Anytime you see green in the medical field, that means oxygen. So on here on the wall, you see we have the green tip, green handle. These placards are green. This is oxygen that's coming out of here. So even if it wasn't labeled, I would know that this is oxygen. In certain hospital settings, some ambulances, you'll have some placards that are yellow. Yellow just means regular air. So it's only 21% oxygen, mostly nitrogen. Got the argon, all the other stuff that's in our atmosphere. That's what's coming out of a yellow one. But if it's green, it is 100% oxygen, nothing else. You have a regulator gauge, which tells you how much PSI is in this. Now, note that I said PSI, not oxygen. It doesn't tell you how much oxygen is in the bottle. It just tells you how much pressure is in the bottle, because it's the pressure that actually delivers the oxygen to the patient. If it runs out of pressure, it's like any other spray can. It might still have something in it, but it can't get out. There's nothing to push it out. We have our regulator up here, or our flow meter. This is where we set how much oxygen we're going to deliver to our patient, and it's done by liters per minute. So when we start talking about our oxygen delivery devices, this is what I'm referring to. So on this O2 cylinder, you would just rotate this tan thing, and it gives you a number. It's a preset number that says 1.5, 2, 3, 4. Some of them go higher, but we typically aren't ever going to go higher than 15 liters per minute, which we'll get to when we start talking about this and the non-rebreather. Some do go higher. A lot of them just stop there. This port right here, this small port, That's going to be where you hook your O2 up. The actual line that's going to run to your patient is going to connect right here. And then that way, whenever you do set this, oxygen can get from the bottle to your patient. Again, this one is preset. You're not going to really take this off. Some of them have regulators that slip on the top, and we'll go over those in your skill days when you see those. If you're fortunate enough to have something like this makes your life easy, because all you have to do is just grab the bottle, connect your oxygen delivery source if you're going to use a non-rebreather, nasal cannula, or the back valve mask. Set your liters per minute, depending on what you're using, and then put it on your patient. One other thing. When you're using the bottle, it's very easy to knock things over, especially in an emergency when we're always moving fast. We've got that tunnel vision going, our pulse is high. Don't set the bottle up like this, because if you bump it and knock it over, if you damage this is high pressure. If you knock this off, if you damage it, it can become a torpedo. Now, it might be fun to watch, one of those hold my beer moments, but we don't want to be around it when that happens. So if you don't have your hands directly on the bottle at any given time, lay it down. That way, the worst thing that can happen is it rolls, and you can grab it or whatever. It's not going to fall or anything of that sort. All right, let's set this here now. So let's talk about oxygen delivery devices. We have a couple of different ones that we use, and we use them based on the severity of our patient. So we have low flow, high flow, and emergency oxygen, and it typically goes in the order of severity. So if I am hypoxic, one of the first things that's going to happen to me is I'm going to get anxious. I'm going to start to look around. My eyes are going to get a little bit bigger. I'm going to be like, something's wrong. I can't relax, right? That's your first sign of hypoxia. So you may show up to patients that that's what you see. They're breathing a little quicker. Their pulse is high. They look anxious, but they're alert. Everything else seems to be fine. If that's the case, you really don't have to overflow them with oxygen. We don't want to give too much. So what we can do is use a low flow oxygen device, which is called a nasal cannula. So again, this is the part that's going to connect to the O2 tank, and then this goes in your patient's nostrils. When you're setting this up, it's important to remember that everything, all the tubing stays in front of your patient no matter which one of these you're using. So if I'm behind my patient, that can get a little tricky, because a lot of times we want to just flip over the top from here and hook it in. But what that does is it basically creates a noose around your patient like this. Their head's in the middle of it, and that's not a safe thing. If something were to happen, that could actually become a choking hazard. You'll notice that the nasal prongs are curved. If I can get it to show properly. There we go. So you want them to hook into the nose, not out into the front, because then they just seal themselves off. But everything stays in the front of the patient. So you're going to take it, put it in the nose, pull around to the side, and hook it around the ears. Just like this. Alright? And then just tighten this up so it stays in place. Now, everything is in front of the patient. So if we have an accident, let's say something happens, the tubing gets yanked, it comes off. It doesn't actually hook onto the nose. When we're giving oxygen with this, it's considered low flow. In other words, we're not going to use a whole lot of this. So remember, I was telling you that you would set your liters per minute. If I'm going to use a nasal cannula, my liters are going to be 2 to 6. That's as high as you go. Anything less than 2, and you really don't get much out of this. Anything more than 6, and you're going to over pressurize this tube, and it's going to keep popping off. So it's a little self-correcting if you don't remember it. If you put this on there and you try to crank it to 15, like we're going to talk about with the non-rebreather and the back valve mask, this tubing's not going to support that. It's just going to pop off. All right. So this is for mild hypoxia. Anxiety attacks are a good one. Anything. Maybe somebody's been running a race and they're a little out of breath, and you're not quite sure if that's trouble breathing or if that's because they were just running or some kind of exercise. You can use a nasal cannula just to kind of check it out. as they do continue to get more hypoxic, whether, let's say they've been having trouble breathing and that's why they call 911, and then you have to factor in the dispatch time, your response time, your travel time to the scene, getting to the patient, because that's not always easy. Even once you get there, it may take you a while to reach your patient. Sometimes their hypoxia is a little bit more developed by the time you get there. So we have what's called the non-rebreather. This you've probably seen. We see this a lot on television. There's a couple of things for this. First of all, this is what we consider to be high flow oxygen. So we need to give more oxygen than what we were doing with nasal cannula. We can use this. And all it is, it's called a non-rebreather because when you put this mask on them, it's not airtight. As you can see, there's no way to really get a seal with this, but they're going to breathe from the bag. And it's so close to being 100% just from this bag that's what we consider it. When they breathe out, it comes out of these little flaps here. This one's missing the valve, but there's going to be a valve there, so when they breathe out, they're not breathing back into the bag. It's just coming out the sides of the mask, and then their next breath comes from the bag again. So what we're going to do, I'm going to show you with this. I'm going to actually show you how to hook this one up because there's a couple steps to it. So the first thing we want to do is get the tip and connect it to the oxygen source, which is in this case this O2 cylinder. We unwrap it, unfold the bag. Now a lot of times, because of the way that they pack these, the bag is very, very stuck together. It's not going to inflate much, and the patient breathes from this. So if we crank the oxygen on, stick this on the patient, and expect them to breathe, if the bag's not inflated, they're not really getting the air. They're going to be getting it pulled in from the edges of the mask, which is just regular room air. So when I crank, actually this one may do it, we're having to see. But when you turn this thing on to 15 liters, the bag may not inflate. So what we'll do, this tip right here is also a valve. Everything's going to flow the path of easiest resistance. So if oxygen's coming in here, if the bag has been too tightly wrapped inside of its packaging, it's going to create too much resistance for the air to get in, and it's just going to blow out the top valve, and that's going to be it. So what we'll do, we'll see if this one does it. Set your O2 to 15 liters, and yep, this is inflating now. If it doesn't inflate, you just take your finger, press down on the valve to create some tension, and it will inflate the bag. Once the bag's inflated, then you can put it on your patient and let them breathe. Watch the bag for a second. The actual range for providing oxygen with a non-rebreather is 12 to 15, so you don't have to go straight to 15. However, if your patient is hyperventilating, maybe they're taking in extremely deep breaths, and they're really sucking this bag down to the point where it's collapsing the bag, maybe their next breath's not going to be a full one because there's not enough air in here, you can crank it to 15. But don't go any higher. If you go too much higher, again, the tubing is not really meant to support that. It can pop off. The last oxygen delivery device that I want to go over is going to be the BVM. And this is what we typically use the BVM for. I know we were talking about it with Airway a little while ago, but a lot of times when we talk about the bag valve mask for patients in EMS, we're talking about breathing for them. So their airway is being fixed with, let's say, an OPA, and they don't have any fluid in their lungs. We're not worried about pushing that out. We're using this to deliver oxygen. We're going to use this when patients aren't breathing well enough on their own to support life. So they may have a good airway, but let's say they're in cardiac arrest, so they don't have a heartbeat and they're not breathing. Or they're in respiratory arrest, which they do have a heartbeat, but they're not breathing. If they're not able to breathe on their own, we'll use this. So you take your mask that's imaginary today. We're going to make that seal on the patient and breathe for them. To deliver oxygen, there's going to be something similar to, it's just a tube. It's going to have the connection that goes on the O2 tank on both sides of the tube. So you're going to connect one here to the oxygen port, and then one to your oxygen source, which is your O2 cylinder. This is only 15 liters. There is no 12 to 15 like the non-rebreather or anything like that. If you're going to use this, set it to 15 right out the gate. That's your only number you have to remember. That's going to fill this oxygen reservoir bag, and then you're going to be good to go. Now, I will say this, unlike the non-rebreather, this does not have to be inflated first. All right, so if you put this on there and you're ready to breathe for your patient, you don't have to wait for the reservoir bag to fill before you can deliver oxygen. It fills the football first, then it goes here. So as soon as you connect it, you got to set to 15 liters, go ahead and make your seal and start bagging for your patient. Just remember, don't freak out. You don't want to squeeze all that air into them. So how do we know which one we want to use? We've got, and this is going to be discussed more in your lecture as well, but if you think about it since we're here, we've got varying degrees of trouble breathing. We've got people that are just a little hypoxic in there, but think like you ran a race, right? You're out of breath, you're breathing heavy. You're breathing heavy because you're hypoxic. That doesn't necessarily mean there's anything wrong. You're not passing out, hopefully, but you could use a little bit of supplemental oxygen, probably wouldn't hurt. That's going to be the times where we use the low flow nasal cannula. From a vital sign perspective, we want to keep our O2 sats on our patients between 94 and 99%. You don't want to be less than 94 because then they're still technically really hypoxic. And anything over 100 or 100 or over is actually a misreading by your equipment. And it can be harmful if we give them too much. Back in the old days, we used to go straight to the non-rebreather, 15 liters per minute. Everybody got it. Whether they were really needing it or whether they just stubbed their toe or had a tummy ache or something of that sort, they got 15 liters of oxygen. It was just easier. The problem is that all that excess becomes free radicals in your system, and on the biologic level, which I won't get into, it's like wrecking balls flying through your system, so you can actually cause more harm and kill your patient by giving them too much oxygen. So we want at least 94, no more than 99. Don't be afraid to use low flow oxygen. Don't be afraid to use high flow if they need it. If they are starting to lose consciousness or if they have an altered mental status, we will typically go straight to the non-rebreather. You may have to dial it down from 15. Remember, you can go as low as 12 and be okay. A lot of times when they're altered like that, either A, they are hypoxic enough that they need that, or B, there's going to be some medical conditions that you'll learn about that are exceptions to that rule. Strokes being one of them. A lot of times we will give them as much oxygen as possible, even if the numbers don't say anything. Or carbon monoxide poisoning. When we start talking about vital signs, we're going to talk about the O2 sat and the limitations of it. If they're breathing carbon monoxide or some other kind of harmful gas, you can't trust your O2 sat. It may tell you they're at 100%, but it's not oxygen that it's reading. If they're completely unconscious and not breathing well enough on their own, then we're going to use this. So it really becomes a decision of, are they breathing or are they not breathing? If they are breathing, regardless of the O2, if they're breathing well enough, we're going to use one of these. If they are breathing and they're breathing pretty well, we're going to use this. If they're altered, they are breathing, but you can tell that they're hypoxic, be it that they have cyanosis in the nail bed, cyanosis around the lips, things of that nature, we're going to go to the higher flow. If they're not breathing well enough on their own, because they have to be able to breathe it in on their own, this doesn't shove it into their lungs. If they're not doing it well enough on their own, then we're going to switch to the BVM. All right, 15 liters only, 2 to 6, and the non-rebreather is 12 to 15. Those are going to be your oxygen delivery numbers that you set on the O2 cylinder. You may get this question in class, and this is something that you can take with you to the field. Remember that the non-rebreather does not create a airtight seal around the face. So let's say that we have a patient that your paramedic tells you they want you to deliver as much oxygen as possible. All right. How do we do that? Because our non-rebreather is limited to 15. What if I want to give them more? Stroke patients sometimes you'll want more. You can actually you'll hook your non-rebreather to one bottle, 15 liters, put it on their face. If you've got it, which in a truck we do, right? We have oxygen in the walls. We also have spare oxygen bottles in case we run these things out. You can take a second bottle, hook the nasal cannula up, 6 liters. So now I've got 2 oxygen sources running to my face. One's got 15, one's got 6. That's 21 liters of oxygen per minute. That will definitely get my O2 sats up. Again, that's going to be very rare that you have to do that, but there may be occasions where that's the case. So that's going to be it for breathing. Remember, Airway is all about just making sure that we have a route. So OPA, NPA, if you can't use the OPA, we can use this for A. Once you've got the route, then we're going to move to our O2 delivery, which is breathing. And we're going to use either the nasal cannula for low flow, which is not non-emergency, but it is a little bit, so if you get to the scene earlier and you can head things off before they get that bad. Non-rebreather if it's bad on the O2 side, but they are still breathing on their own. And then if it's really, really bad, the bag valve mask. Alright guys, I hope you enjoyed having this video where it's actually, you know, us in a truck as opposed to your typical lectures of the slideshow and everything. We are working on making these better for you. I'm going to be doing a whole series of things in the truck. We're also going to be talking in the fire service. We'll be going over some things that may be in the industrial field, because you're not just limited to the ambulance, even though a lot of what we do in EMS, especially on the transport side, does happen in here. And as you can see, you've got a lot of stuff that you get to deal with. These are like portable facilities these days. They're not like the old days where somebody just had a stretcher and a cabinet and that was it, or in the really old days where it was in a hearse. That way, depending if you made it or not, determined where you went. I appreciate you guys being here listening to me. I want to bring up a couple of things. If you're interested in learning more about how things kind of flow in the field, we do have a podcast. You can tune into that and listen to us. We just talk about things that you're going to be seeing, or things that we're seeing in the field. We're going to discuss new trends, events that happen in education as well as operations. You can also check out our nonprofit. We have one called the Airway Responder Relief Project, where we build scholarships in public safety for people who are wanting to get in. You don't even have to go to our school. If you get the scholarship, you can take it to any college you want to go to. We do hope you come to us, but you don't have to. Something else that we do is we raise funds for injured or sick first responders and their families. For example, at my fire department, we have 3 firefighters that are fighting cancer. Money for them. There's an NYPD officer that his wife is fighting breast cancer, and we're raising money for him. So it's not just the responders themselves, but also the family. We also raise money for responders who are in disaster-stricken areas. When a hurricane hits the area, our responders are out there taking care of their communities while their own stuff is laying in shambles possibly. So we try to help out with that. If you want to donate or volunteer time to help us grow, that would be fantastic. You can check that out at www.aresresponderrelief.org. So ARES responderrelief.org. Thank you all for listening. Have a great one.